Welcome to Dinet Discussions, a speaker series. My name is Ellen Driscoll. I am the president of the board of directors for Dinet, which is the Dysautonomia Information Network. For those of you who may not be familiar with our organization, we are a volunteer nonprofit that is dedicated to enhancing awareness of dysautonomia and providing support and education for people living with the disorder and their caregivers. So joining me also from Dinet is Lauren Malak, who is vice president of the board of directors.
Hi, everyone. Thank you so much for joining us again this week.
So this is the second in a four-part series continuing through the month of October into the first week of November. And before we begin, I want to give a special thank you to our sponsor, Banana Bag Oral Solutions. Banana Bag is a drink that brings the benefits and nutrients of IV hydration therapy without the need for the IV. So for this month, for Awareness Month, Banana Bag is offering a special discount to anyone watching this video who'd like to try the product. And in the video description at the bottom of the screen, you will receive a code to get that special discount. So today's session is COVID-19 and dysautonomia, what is known and what is not. And it is presented by Dr. Svetlana Blitshteyn. We are very excited to have her here with us today. And Dr. Blitshteyn is the director and founder of the Dysautonomia Clinic in New York State. She is a board certified neurologist, as well as a clinical assistant professor of neurology at the University of Buffalo. We are very honored to also have Dr. Blitshteyn as part of our Dinet Medical Advisory Panel. And she also serves in that capacity for Dysautonomia International, Standing Up to POTS, and the Ehlers-danlos Society. Dr. Blitshteyn has been the principal investigator in many vital research studies about dysautonomia, including POTS and autoimmunity and POTS and pregnancy. She co-authored a popular patient handbook. If you haven't had the opportunity to read it, I really encourage you to do so. It's wonderful. It's called POTS, Together We Stand, Riding the Waves of Dysautonomia. She also played a critical role in one of Dinet's original documentary films entitled Changes, Living with POTS, which is also available on our site and on this YouTube channel. Dr. Blitshteyn's work continues to have a profound impact on the field of dysautonomia, and we are very grateful that she was willing to share her time with us today. Hello, Dr. Blitshteyn, so good to see you.
Hi, Ellen and Lauren, thank you for having me.
I'm going to turn this over to you, and we will be back at the end with patient questions at the end of the session. Thank you.
Okay. Thank you for inviting me to give this lecture on long COVID and post-COVID dysautonomia. I have been medical advisor for Dinet for at least 15 years. So I was working at Mayo Clinic when Michelle Sawicki, the founder of Dinet, invited me to be on the medical advisory board. And I'm happy to see that this organization continues the good work on education and awareness. So today I'll be talking about long COVID, how COVID infection can result in new onset dysautonomia, and we'll also talk briefly how COVID can affect individuals with pre-existing autonomic disorders. And of course, we'll talk about COVID vaccines at the end. To date, 7 identified coronaviruses have been found to infect humans. And of these, 3 highly pathogenic variants have emerged in 21st century. The newest member, of course, as you know, is severe acute respiratory syndrome coronavirus, SARS-CoV-2, and it was first detected at the end of 2019 at Hubei province in China. Since then, this novel coronavirus has spread worldwide, changing our world and changing our lives. Coronavirus particles comprise at least 4 structural proteins: the spike protein, envelope, membrane. and nucleocapsid where the RNA is located. In this lecture, I will use the term PASC, or post-acute sequela of SARS-CoV-2 or COVID-19, which is the term used by the NIH. But this syndrome has been originally named by the patient-led groups as long COVID. There are other names circulating in the literature, such as post-COVID syndrome and others. So what are the estimates on the prevalence of PASC? So as you see from this diagram, as of September 1st, there were 39.3 million cases of COVID in the United States and 218 million globally. If we take the lowest possible estimates of long COVID as the lowest 10% in order to make our calculations easier, we end up with 3.93 million cases of long COVID in the US and 21.8 million worldwide. So that's a lot of people who are symptomatic, disabled, and in need of diagnosis and management. Symptoms of PASC are numerous and multisystemic and usually involve cardiovascular, neurologic, and other systems. And if you look at these symptoms in the table taken straight from the CDC, you see the similarities of symptoms to dysautonomia, ME/CFS, and mast cell activation syndrome, fibromyalgia, and others. So what are they listing as? Of course, shortness of breath or dyspnea, fatigue, post-exertional malaise, brain fog or cognitive impairment, cough, chest pain, headache, palpitations or tachycardia, that's prevalent, arthralgia, myalgia, numbness or tingling, the word for paresthesia, GI symptoms, insomnia, impaired daily functioning, lightheadedness or dizziness, pain, rash, think about mast cell activation syndrome, mood changes, anosmia or dysgeusia, which are words for loss of smell or taste, menstrual cycle irregularities. And again, the symptoms are many, and they are very similar to complex disorders that all of you are familiar with. In terms of post-COVID sequela by systems, this table is again taken from CDC, and it illustrates the scope of post-COVID conditions. Under cardiovascular, there you see POTS, it's listed, and it's right on the CDC website. We haven't seen that before, right? And then under neurologic, you see strokes and TIAs, smell dysfunction, sleep problems, cognitive impairment, memory problems, headache, weakness, neuropathy. Of course, there are other manifestations, essentially covering almost all of the bodily systems here. So more than a quarter of patients develop new neurologic symptoms after their acute COVID infection. Again, this diagram is from CDC, and it summarizes findings of one of the earlier studies from France, which included 70 patients, 78 of whom were women, mean age 45 years, who had persistent symptoms defined as symptoms lasting for at least 2 months after the original infection. Fatigue was noted in 73% of patients. Here's palpitations and tachycardia in 41% of patients. Sensory disturbance or numbness, tingling in 55% of patients. Cognitive impairment in 37%. Subsequently, a number of large surveys were done by patient organizations on long COVID, and their self-reported symptoms correlate with those observed by physicians. This figure shows a study by Hannah Davis and others that notes, again, fatigue, post-exertional malaise, brain fog, sensory symptoms, and headache as the most common persistent symptoms in long haulers. Again, you see the symptoms are very similar to dysautonomia, ME/CFS, fibromyalgia, small fiber neuropathy, and others Among others are post-Lyme syndrome, right? Post-infectious syndromes and Ehlers-danlos syndrome. So dysautonomia specifically has been mentioned early on in literature on acute manifestations of COVID in hospitalized patients and ICU patients. And likely this dysautonomia was of central origin and due to brainstem dysregulation. And then subsequently, case reports of patients who developed autonomic disorders like POTS after COVID infection have been described, and these consisted of 1 to 6 patients series. And PASC has been defined by the NIH as symptoms that persist for more than 30 days, and they occur in at least 10 to 30% of adult patients with COVID, and at least 9 to 14% of pediatric patients with COVID. So when we say that children are less affected, we imply that there is less death among children than among adults. But don't forget about long COVID. And it's why we are anxiously awaiting from the FDA to finally grant approval on vaccines for children 5 to 11 years of age. So as early as April of 2020, I started seeing patients with persistent symptoms after COVID-19 who were unable to return to work. My first patient was a medical doctor in training in New York City who, after a case of COVID-19 without pneumonia, was unable to return to his hospital duties. He told me that a number of other doctors in his hospital, including his cardiology attending, were unable to return to work 2 weeks after the illness due to fatigue, palpitations, and exercise intolerance. He and other doctors thought they may have POTS, which is how he sought me out. He did subsequently improve and was able to return to his hospital duties. So from then on, I began seeing patients with post-COVID POTS and other autonomic disorders, which led to my paper that you're seeing here. In this case series consisting of 20 patients, 70% were women with a mean age of 40 years. 6 had pre-existing minor autonomic symptoms like occasional dizziness, palpitations, maybe presyncope occasionally, and 4 had a remote history of concussion, but no patients had orthostatic intolerance or autonomic disorders prior to COVID. None had severe COVID requiring hospitalization. And in this big table, if you read a full-length article, you'll see the description of each patient, their symptoms, treatment that I used, and their outcomes and additional information for those who are interested. In this table, you see the summary of our findings, and you see that POTS was the most common autonomic disorder, occurring in 75% of my patients. Vasovagal syncope was found in 15% of patients, or neurocardiogenic syncope, in another name for it. And orthostatic hypotension was found in 10%. In my cohort, 100% recovery occurred only in 3 patients, and residual symptoms were present in 85% of patients 6 to 8 months after acute infection. We had 60% of patients who were unable to return to work, and 40% were able to work either part-time to full-time with accommodations. 30% had abnormal cardiopulmonary tests, and 20% had elevated markers of inflammation or autoimmunity. But not all patients were tested due to the pandemic lockdowns and patients having no access to labs. So in this figure, once again, we show that POTS was the most common autonomic disorder in my case series. And we also show the disability and prognosis that 60% were unable to work 6 to 8 months after acute infection, and only 15% were able to go back to work full time as they were before. These were our outcomes. Subsequently, another case series was published on autonomic dysfunction after COVID from Mayo Clinic. They had a total of 27 patients, but they combined new onset autonomic disorders with patients with pre-existing autonomic disorders. So in other words, people who had autonomic neuropathy and then developed COVID. All patients had complete autonomic function tests, and 63% had abnormal findings. But in their case series, only 22% had POTS. So their findings are a little bit different. And the most common autonomic disorder that they saw was termed orthostatic intolerance. So the study did not report any outcomes of these patients, which would be interesting to know. So what has been discovered in long COVID? I am going to present a number of very interesting studies today that I believe are relevant not just to long COVID, but to dysautonomia, POTS, and ME/CFS research in general. The first study that's important is on patients recovering from COVID who wore wearable heart rate device monitor comparable to Fitbit. And in this study of 875 patients, 71% of whom were once again women, it was found that patients who tested positive for COVID had an elevated heart rate for 79 days after the initial symptoms. And 14% of patients continued to have elevated heart rate for more than 4.5 months. So heart rate elevation is noted in post-COVID patients. The authors concluded that COVID-19 alters the autonomic nervous system. Very important study in JAMA. In another interesting study, 16 patients, mean age 20 years old, so young college students, had autonomic function tests after an average of 35 days after their positive PCR test. What was found there is there was elevated resting sympathetic activity in this patient population and suppressed sympathetic activity and pain perception during cold pressor test. There was also a higher sympathetic activity on the tilt table test, including elevated heart rate, with some patients actually meeting the diagnostic criteria for POTS. This is in young, recovering healthy college students. Imagine what the findings would be in older individuals with COVID. So another important study. This is a very interesting small study from a collaboration of Harvard and Yale pulmonologists, including Dr. David Systrom, who studied exercise intolerance with invasive cardiopulmonary testing before the pandemic. So when they did cardiopulmonary testing on 10 patients and compared them to 10 healthy controls, they found reduced aerobic capacity in patients with reduced VO2 max. Now, it used to be that this reduced VO2 max in the past was considered a marker of deconditioning. And now we know that is not the case, because in the study, this reduction was associated with impaired systemic oxygen extraction. So there is more to VO2 max than just being out of shape. There are other parameters that go in there. And that's what the study is showing. Again, applicable to probably our patients with other types of POTS. Next, a study that used PET scan of the brain in patients with long COVID and compared them to healthy controls. And patients with long COVID had hypometabolism in many regions of the brain and brainstem. I'll just name a couple: is the olfactory gyrus, where you have a sense of smell. Temporal lobe, amygdala and hippocampus, very important in memory. Medulla and pons, medulla and pons, very important for regulation of the autonomic nervous system. And the cerebellum, The cerebellum is a part of the brain that controls your movements and balance. And so these hypometabolic areas were associated with occurrence of hyposmia, anosmia, memory, cognitive impairment, pain, and insomnia. So now we are showing actually PET scan changes in the brains of patients with long COVID. Next, we have a G protein coupled receptor antibodies in long COVID study. Recall that G protein coupled receptors antibodies were found in patients with POTS by different research groups over the past 5 years. And this study from the founders of Berlin Cures Lab in Germany, they found antibodies in patients with long COVID, the same ones. Antibodies included those to beta-2, alpha-1, muscarinic-2, angiotensin-1, and endothelin receptors. And the beta-2 and muscarinic-2 antibodies were seen in all 31 patients. Now, this study did have a major limitation because it did not have a control group. But there is also another case report currently in the pre-review form, not published yet, that describes one patient with long COVID whose symptoms reversed after they treated this patient with a DNA aptamer drug for high affinity to GPCR antibodies that neutralizes these antibodies. This aptamer is called BC007, kind of like James Bond 007. And hopefully we'll see these studies in clinical trials of many patients, we hope. One of the first studies on post-COVID patients came from Germany, where researchers utilized cardiac MRI in post-COVID patients that included hospitalized patients. The study had 2 control groups consisting of healthy people and people with risk factors matched to patients. So people with hypertension and high cholesterol and prediabetes. Cardiac MRI was done on these patients at mean 71 days after their COVID virus was diagnosed. And symptoms on the day of that MRI included shortness of breath, exhaustion, atypical chest pain, and palpitations were present in 20% of patients. So abnormal cardiac MRI was indeed found in 78% of patients, with 60% having evidence of ongoing myocardial inflammation. Here we see this MRI and you see these errors and abnormal findings of inflamed covering of the heart and the outer layer of the heart. So this is abnormal evidence of cardiac inflammation. Why is it important to our field? Is because we don't know what kind of MRI findings may or may not be there in patients with post-viral POTS or post-viral dysautonomia. And I think that's something important to keep in mind. Is there inflammation or is it not? That's important to figure out for future research. Next, I want to include a recently published study from Dr. Weizstock and Dr. Afrin on mast cell activation symptoms in long COVID patients. It was just published and came out just a few weeks ago. The study compared 136 patients with PASC, 136 healthy people, and 80 patients with MCAS by using a questionnaire on MCAS. And what they found is that pre-COVID, PASC patients were very much like healthy controls with minimal to no symptoms. But after COVID, PASC patients were very much like MCAS patients in terms of their symptoms and questionnaire scores. So they concluded that aberrant mast cells activated by COVID virus is a possible mechanism of PASC and suggested that maybe MCAS therapy with antihistamines and mast cell stabilizing agents may be beneficial for patients. So we're going to switch gears a little bit because we need to think about what is the pathophysiology of POTS before we think about what is the pathophysiology of PASC or long COVID. And we often say that POTS is multifactorial, multisystemic, and complex. And this is a figure from my recent paper called Is POTS a Central Nervous System Disorder? And it shows all of the known factors in POTS pathophysiology involving the mechanisms that are well established, like the G-coupled protein receptor antibodies, like hypovolemia, cerebral hypoperfusion, and abnormalities in renin-angiotensin-aldosterone system. Note that this is a proposed model and not a proven model, but this is a good working model for me and hopefully for others. So from a few research studies pre-pandemic, we learned that there may be evidence of inflammation, possibly at the brainstem, possibly at the dorsal medulla, which is part of the brainstem. And we learned that autoimmunity, inflammation, and immunologic changes may happen in patients with POTS and also in patients with post-COVID syndrome. So other genetic and sex differences in terms of the individuals affected with POTS and long COVID, I think that's where research should go, considering that the demographics of the two populations that we're seeing is quite similar, consisting predominantly of women in their 30s and 40s. And so next, let's talk about pathophysiology of PASC, proposed pathophysiology. There have been a wide variety of studies over the past year demonstrating various pathophysiology in long COVID patients. In the slide, I summarize what's been available in the literature to date. Several themes emerge, such as, once again, autonomic dysfunction, inflammation, autoimmunity, immunologic changes in the T cells, and endothelial dysfunction. And they're in red because I think they're very important and kind of make sense if you think about POTS pre-COVID. But there were also other studies on oral and gut microbiome disruption, on metabolic abnormalities in long COVID, on kidney damage risk, peripheral vascular vasodilation impairment, and even biological age acceleration and telomere shortening, which is a genetic change. So I think there are also genetic and sex differences here in PASC as well. And you see how closely intertwined these pathophysiologic mechanisms are in both disorders. We need to briefly talk about treatment of PASC. And this is, again, treatment, how I approach it, right? And you can read more on treatment that I used in the paper that I had there previously on post-COVID POTS. So if there is POTS and orthostatic intolerance present, you treat that. If there are mast cell activation syndrome symptoms present, you address that. If patients with PASC have headaches, insomnia, and pain, we treat that as neurologists or primary care physician or rehabilitation doctors. What else is available? Well, of course, we're going to employ treatment for dysautonomia pre-COVID. We're going to employ that towards patients with post-COVID dysautonomia. And we recommend fluids intake and sodium chloride consumption. Compression garments can be utilized. Diets can help as well. We just completed a study on gluten-free diet in patients with POTS, and many had mast cell activation syndrome and EDS. Pacing, mild exercise, psychological support, those are non-pharmacologic therapies. Medications that I like to use are beta blockers at a low dose, not just to reduce the heart rate, but also to reduce general sympathetic overactivity and symptoms that can be caused by that, such as anxiety, physical anxiety, insomnia, tremors, this internal vibration feeling that a lot of long haulers talk about. We have Florinef, we have Midodrine, Mestinon, we have Ivabradine or Corlinor for patients who do not tolerate beta blockers well or have contraindications to beta blockers. I use it then. Antihistamines, tricyclics, which are medications at low dose. They are for neuropathic pain and headache. Gabapentin is our neuropathic pain medication. I use stimulants like Adderall or Ritalin or Vyvanse for patients with fatigue and brain fog. SSRIs can certainly be used, especially if there is significant anxiety or depression. I also use low-dose naltrexone in selected patients. But I need to mention something is that many times long haulers come to me and they put themselves on a bunch of vitamins and they want all of these medications, including low-dose naltrexone, because they've read somewhere on the internet that these are good medications. So it's very important to understand these medications are going to be chosen based on your individual symptomatology. And so an individualized approach is best, not just kind of, well, these are good, because everyone is different and everyone's symptoms and presentation will be unique to them. So what vitamin supplements we use, vitamin C, D, magnesium, quercetin, CoQ10, B12, iron supplements for those who have iron deficiency with or without anemia, and there are others. We certainly can use IV saline on as needed basis, but not daily or not, a few times a week, because we certainly want to avoid placements of PICC line or port, as they are a risk factor for sepsis and blood clots. Oral steroids, a short course of oral steroids I have used. Now, can we use IVIG or subcutaneous immunoglobulin? Well, this is what a study right now at the NINDS is going to answer. We hope so. There are certainly a few case reports in the literature on the use of IVIG in post-COVID patients who were very sick, with post-COVID symptoms. We know that pulmonary rehab and cardiac rehab can be beneficial. And then we have other adjunct therapies like biofeedback, neurofeedback, cognitive behavioral therapy, group therapy. They are certainly helpful, but they are not curative by any means. So ultimately, studies of post-COVID dysautonomia would be beneficial to patients with dysautonomia of any type. And studies on POTS and ME/CFS pre-pandemic are certainly relevant to patients with post-COVID POTS and ME/CFS. So a lot of people ask me, is post-COVID POTS the same as regular POTS? We don't have comparative studies yet, and we don't have prognostic studies yet. But the NIH is currently working on a number of studies where full autonomic function tests, cardiac MRI, and inflammatory markers would be used. These studies are currently underway and recruiting patients. I have referred a few of my patients there because NIH has received nearly $1.2 billion from Congress for a 4-year long COVID research. So hopefully we'll get more answers there. Of course, what I observe in my clinic is that post-COVID POTS patients may have additional cardiac, pulmonary, and thrombotic manifestations that may not be seen in other POTS subtypes. Now, the good news is that as of October 2021, long COVID received its own classification diagnosis, ICD, and then as of July 2021, Americans with long COVID are entitled to disability rights under the Americans with Disabilities Act. This is all great and sort of accelerating the research and the, I think, advocacy of on regular POTS, because there is no diagnostic code for POTS yet. And I don't believe that POTS is all accepted diagnosis to receive disability, because I have been involved in several cases of disability on my patients with POTS. So this is good news. And hopefully, pre-COVID POTS can work off of this as well and benefit patients and physicians. So what about patients with pre-existing POTS and COVID-19? How do they fare? Now, this is a common question, but there are no studies to date that determine the course of POTS and COVID infection in patients with pre-existing POTS. The only study that I'm aware of that sort of attempts to address this question is my study that I presented at the American Academy of Neurology meeting last year called COVID-19 in patients with pre-existing neurologic disorders, clinical course and outcomes. It's in the abstract form. So this study I did in spring of 2020. At that time, there was very limited data. We only had 3 patients with spots who had COVID infection. I did include them in the study. There they are. And when we pulled together with patients with other neurologic disorders, we found that 57% of patients felt that their pre-existing neurologic disorder, including POTS, was worse during or after COVID. All right, so in the sample, we had 66 patients with all kinds of neurologic disorders, and majority did have mild to moderate course of COVID-19. They required no hospitalization. But many patients did have persistent symptoms of fatigue, exercise intolerance, anosmia, sleep disturbance, and headache. So what do we know? We know that COVID can make your pre-existing neurologic disorder, whether POTS or chronic migraine, there were 23% of patients with chronic migraine, it can make your pre-existing disorder worse. Is that enough? Of course not. We need to know how a lot of POTS patients fare with COVID-19. Okay, so what about long COVID in the vaccinated individuals? We have early data on that, which I pulled from several studies. And in this case, control study from Israel of almost 1,500 fully vaccinated healthcare workers. Most breakthrough COVID cases were mild and asymptomatic. And the breakthrough rate was 0.4%. Now, I think this is I believe this was with Delta variant. So 0.4% is pretty good. 19% of breakthrough patients had persistent symptoms of anosmia, cough, fatigue, weakness, and shortness of breath beyond 6 weeks. Okay, and one patient was unable to return, one healthcare worker was unable to return to work. So is long COVID possible in vaccinated? It is possible, but the chances are much less of that happening. And there was another study. This one is from UK. It's a case control study where COVID breakthrough rate was 0.5% after the first vaccine and 0.2% after the second shot. So importantly, vaccination in the study was associated with reduced odds of hospitalization and of long COVID following vaccinations. And the authors conclude that being fully vaccinated reduces the odds of long-term COVID symptoms by a half. And you can see how that plays out in the odds ratio table here. So finally, this leads us to a very important topic, vaccination, right? Vaccination is one of the most effective public health measures we have against COVID and its complications, including long COVID, as I just discussed in previous slides. Many patients with dysautonomia and other chronic disorders have expressed hesitation and concern regarding vaccination. And these concerns are certainly valid. As I always explain to my patients, if you're worried about adverse events from COVID vaccines, imagine these complications multiplied by 10 if you have the actual COVID virus. So the risks of COVID virus far outweigh the risks of COVID vaccines. Regarding post-vaccination adverse events, what do we have in the literature? Not much. We have 2 case reports published thus far. One was new-onset POTS after vaccination, and another of small fiber neuropathy after COVID vaccines. There is also a case series of 27 patients, where 17 patients with pre-existing rheumatologic disorders experienced transient worsening of their disorders, and 10 had new-onset autoimmune disorders after COVID vaccines. So if you have concerns, you should obviously discuss this with your doctors specializing in POTS and mast cell activation syndrome. But you should understand that risk of COVID virus versus COVID vaccines, virus is worse, okay? So it's important to note that dysautonomia and comorbid conditions, including mast cell, including ME/CFS and EDS, are not contraindications or exemptions to COVID vaccines. So my take-home message today is please get vaccinated and protect yourself and your family. Okay, so thank you for your attention. I tried to make this lecture concise in order to bring the most interesting research on long COVID to you. Many other good research studies have been done, which I didn't have time to cover today. Here is a photo of our most recent research team that worked on gluten-free diet in POTS study. We had the mini party pandemic style at the study's conclusion. So next to me here, you see Kate Zah, who is a fourth-year medical student who is currently applying to neurology residency. You see Dr. Abigail McLaughlin, who is currently in training to become a physiatrist in Texas. You see Jill Brooke, who is our research assistant and also works as a nutritionist at the Dysautonomia Clinic. And at the bottom here, you see where the Dysautonomia Clinic is located in Williamsville, New York. So I'll take your questions now, and I hope you learned something new today.
Thank you so much. That was wonderful. Go ahead, Lauren, you have some questions?
Yes, that was very informative, and I totally agree. You know, if nothing else, with all of this, as horrible as COVID has been, I really hope that it continues to bring light to POTS and dysautonomia in general, and give it some much needed awareness and focus on it, because still to this day there really isn't a lot of knowledge about it. It seems like, you know, you'll go to a new doctor, and if they don't specialize in dysautonomia, they've never heard of it before. So hopefully that definitely helps shed some light on everything. Most of my questions I think you answered, but I have a couple for you still. So from our members, one asked if they're curious if long haul post-COVID syndrome is similar to other post-viral conditions like post-viral malaise.
Yeah, it's a good question, which I touched upon in the lecture. Certainly, there are so many similarities, but we just don't know yet if it's exactly the same or is it different, because this COVID virus is new. And it appears that it not only causes post-viral dysautonomia, it can cause blood clots, it can cause cardiopulmonary manifestations and lung damage, even in mild cases. So we just don't know yet. But certainly it seems to be in that category of post-viral syndromes.
Okay. And then another one we've received was, are the symptoms that come with post-COVID POTS similar to POTS-like symptoms that many women get during pregnancy but go away on their own after they've given birth?
Well, this question has a couple of parts. Number one is there might be symptoms of pregnancy that are very common, you know, dizziness and fatigue, and sometimes even, you know, increase in heart rate and palpitations. But that certainly doesn't constitute an autonomic disorder, right?
Okay.
Because autonomic disorder has diagnostic criteria that's way beyond, you know, normal pregnancy symptoms. And we know that POTS can start during or after pregnancy. There is a postpartum onset. So is it like that? I don't think so. I think you can ask any long hauler that the symptoms are quite severe. A lot of them are women, so they can certainly compare and contrast, and will tell you that they've never felt as bad as they do now after COVID infection. So in my clinic, I routinely ask, you know, have you had any post-flu fatigue, or have you had mono, or, you know, so, and of course, over the course of a lifetime, it's expected that people will have, you know, various viruses and gastroenteritis and possibly influenza. And I have to say that almost no patient ever to me reported that, yes, I felt like that in the past. Most will tell you that this is way worse, way more severe, and way more disabling.
Wow.
I do have one quick question that I'm very curious about. First of all, I am so surprised to learn, almost shocked to learn how much worse this post-COVID long haulers is. It's been touched on in the news a little bit, but not to the extent that the studies report, to the point where they would actually have a diagnostic code for it now and have it be considered a disability. When you think of all the years and all the research that's been done on dysautonomia, and we were never able to achieve that. So I'm kind of shocked by that. And one of the questions I was wondering about was, and I don't know if I missed this or whether you covered it, but do you think that people with pre-existing dysautonomia are more at risk for more long-term long hauler syndrome type? Are we more at risk, I guess, for that after?
Yeah, ultimately it's the $1,000,000 question. What are the risk factors? Right now, what we know from research, that the risk factors are you a male or a female? Because women are more likely to be long haulers.
Right.
And then women obviously are more likely to have dysautonomia. Your age, so if you're 30 to 40 years old, but we also have children with long COVID. So these are the risk factors. Now, if you want to be more specific and you look at our study of 20 patients, understanding that this is a small case series, all things considered, is that again, 30% of patients did have some kind of minor history of autonomic symptoms. 20% had concussion in the past. 15% had migraine headaches. So these conditions risk factors? They very well could be. You know, in a different study from Europe, a lot of patients, I think at least 20%, had a history of allergies in the past.
Wow.
So is this kind of allergy dysautonomia process, is that a risk factor? And we have to study this in thousands of patients to come up with an answer.
Right. And a longer period of time, I would expect too, because it's still so new as a virus. I mean, it's still so new to us.
Right.
Oh, really eye-opening. Thank you so much for doing this for us. We've had so many people come onto our site and write to us asking questions who've never heard of dysautonomia or even POTS before, and now find themselves very ill and saying, do you think I have POTS? Because they're reading the symptoms and they know that's what they're feeling like. So it's really important. It's important to all of us. So I really appreciate not only your time with us today, but for all the investigative work you've been doing. It's wonderful. So in conclusion, I just want to thank Dr. Blitshteyn, obviously, and thanks again to our sponsor, Banana Bag. Please visit their site for more information. Thank you all for attending this session. We hope to see you again next week. We will have the premiere of Let's Talk POTS, How to Identify and Manage POTS with Dr. Satish Raj. On behalf of all of us at Dinet, we hope you enjoyed this session and you learned as much as we did. And please be well. Thank you.